So we now move on to the talk on orbital tumors and the current management by Dr. Santosh. He doesn't need any introduction in this forum. So over to you, Dr. Santosh.
Thank you, Seema. I'll be speaking about protocol for the management of orbital tumors the next 10 or 12 minutes. Orbit is a Pandora's box. There is a lot of evil in it, which is actually true because 50% of orbital tumors that you see happen to be malignant tumors, where there is concern about life salvage as well, apart from eye and vision salvage. So your protocols have to be very well defined. When you're dealing with a benign tumor, obviously you would want to remove the tumor completely. When it's a malignant tumor, sometimes you have to use multiple other modalities to treat. The goal always remains the same, irrespective of which cancer it is. First goal or the primary goal is life salvage, secondary goal is eye salvage, and tertiary goal is vision salvage, and you can't reverse these. Whenever you have a patient with orbital tumor sitting in front of you, you have to ask several questions and answer these yourself. What is it likely to be? Where is it located? Is it intraconal, extraconal? Does it have intracranial extension as well? What are its relationships? Is it related to any of the critical structures in the orbit which are functionally important? Is it operable at all or not? What is the approach then? Would it be transconjunctival? Would I cut the bone? Or can I not operate it? Would I need a neurosurgeon to help me? And what do you expect out of it? Do you want to completely remove the tumor? Would you have any complications? Would you explain the patient there's a higher chance of vision loss in a given situation? All these has to be assessed by a good clinical evaluation, followed by appropriate radiology, which could be CT scan, MRI, or both, and sometimes even a PET CT scan. Now, based on that, you arrive at a differential diagnosis, and it is good if you know what is important or what is the most important tumor in your region. This is some Indian data. And also based on whether it's a child, axial proptosis, abaxial proptosis, subacute, or chronic onset, you will be able to further narrow down the differential diagnosis, which is extremely important for you to plan the treatment. And also whether it's a well-circumscribed spheroid tumor, well-circumscribed oblong tumor. Based on that, you will narrow down your differential diagnosis further. For example, a tumor of this sort would be arising from supraorbital nerve, and that is the nerve, and that's neurolemoma. You already know the diagnosis. So you have to explain to the patient there will be consequent loss of sensation in the forehead and scalp if you were to operate this patient. Adenoid cystic carcinoma, obviously, if you know the diagnosis already, you would do multimodal treatment. Triradiate lesions have very specific differential diagnosis. Now, based on this, you arrive at a logical stepwise approach. This would mean that at the end of your clinico-radiological summation of diagnosis, for a set of patients, you would say definite no to surgery. For a set of patients, you would say a definite yes to surgery, and there are patients who lie in the gray zone where you may do surgery or may not do surgery. This is one such situation where there is a metastatic Wilms tumor already where you will definitely not want to do surgery. How do I say that? Because it's a bilateral proptosis in a child with a triradiate lesion, temporal fossa fullness, it has to be metastatic Wilms tumor. There is no other differential diagnosis. In a similar situation where there is periocular hemorrhage or raccoon eye sign, it has to be metastatic neuroblastoma. There is no differential diagnosis. Here you don't need to do surgery. You simply refer the child to a pediatric oncologist. If a child were to have acute proptosis, left eye acute proptosis, subconjunctival hemorrhage, and on seeing the fundus, you have rot spots, this has to be granulocytic sarcoma. You simply do a peripheral blood smear. Don't subject this child to the risk of anesthesia and a biopsy. Peripheral blood smear confirms the diagnosis, and there the child goes to a hemato-oncologist. In a situation of multiple myeloma, this patient had a history of prior multiple myeloma. Where there's a triradiate lesion, you're sure it is plasmacytoma clinically because it's a triradiate lesion. And all that you do here is a FNAC, and that will confirm the diagnosis. You don't have to open up for an incisional biopsy. Now, there are non-surgical approaches as well. This was an airline pilot with evidently no proptosis. He looks very normal, but he has this tumor which is impinging on the superior orbital fissure and the optic nerve with visual field loss, which has failed him in his medical exam, and he can't fly anymore. And that's the only occupation that he has. He doesn't know any other job. So you have to save his vision. And if you were to meddle in this area too much, although it is cavernous hemangioma, he may have a risk of vision loss or visual field loss, which may exacerbate further, or even diplopia. In such situation, we would choose a conservative approach, which is stereotactic radiation. You can see impressive reduction in the tumor volume and consequent reversal of visual field effect, we give a slightly higher radiation here. But we have learned that even a lower dose radiation works. 2000 centigrade was used in this published case, where you see this tumor, which is very much apical, has become much smaller with complete reversal of the visual field effect. So the current concept is, if a tumor is in the shape of a pear, if it is kind of impinging on the superior orbital fissure and the orbital apex, you may not want to surgically operate and consider other alternative modalities. Now, some patients we deal with only injections. There's a young girl who only wanted cosmesis. She's not bothered about anything else. She has recurrent subconjunctival and periocular hemorrhage. She has a lymphangioma, which you may want to debulk, but look at its critical location. Around the optic nerve, lacrimal gland, all the muscles are involved. You wouldn't even want to go by the conservative supratemporal approach here. You would rather give an injection, which could be either picibanil or bleomycin. Here we choose picibanil mainly because it's an intraconal lesion all around the optic nerve, and we know picibanil is safe for the optic nerve compared to bleomycin, which can have visual reduction. So this girl did very well after a couple of injections of picibanil, and for a macrocystic lymphangioma, you would aspirate the contents, which is blood here, and inject 1/4. Initially, we started with an equal amount of injection. Now we learned that a much lower dose of 1/4 of volume of the blood aspirated in a macrocystic lymphangioma can actually take care of the lymphangioma, and it settles down very well. Acute bleed, you would have to evacuate and inject bleomycin. And for anterior lymphangiomas, you simply don't have to do anything. This is a microcystic lymphangioma where there is not going to be any aspirate. You simply inject 1/4 of the volume of the tumor as estimated by your CT scan or MRI. Again, an anterior lympangioma, macrocystic, aspirated and injected. Now you have a situation like this where a child has a tumor which is involving the roof of the orbit, and because of the chronicity of this lesion, we already suspect that the child may have eosinophilic granuloma. Here the approach is going to be completely different. You're not going to curate it only because the dura is already involved here and you don't want any risk to this child. So you would go by a safe approach where you would want to do biopsy from the center of the lesion, which is absolutely safe. Make this child wait under anesthesia for about 10-12 minutes, and your pathologist confirms the diagnosis of eosinophilic granuloma. Sometimes they need IHC, that's a different situation. But if they can actually confirm the diagnosis of eosinophilic granuloma, you go ahead and inject transloan right into the lesion under visualization, and within 3 months you see significant bone remodeling, and within 6 months the bone is completely remodeled without any need for major surgical intervention. So you have an advantage here by having an in-house ophthalmic oncopathologist who would be able to help you diagnose a lesion on the table, and this is exactly a similar situation. Now, incisional biopsy is something most of us don't take very seriously. We would possibly ask our fellows or even junior fellows to do incisional biopsy. But incisional biopsy has a binding on you that you have to make efforts to get the diagnosis. Otherwise, there's no point doing an incisional biopsy. We know that 8 to 20% of orbital biopsies result in non-specific or misleadingly wrong diagnosis, and that is the reason why we have to be very clear when you biopsy it, and you should not have sampling errors. When I look at a tumor like this, I would estimate the epicenter of the lesion. That's the epicenter. So I would do a superficial biopsy, mid-zonal biopsy, deep biopsy, past the epicenter, or you may want to do a biopsy of this sort where you have the entire epicenter already involved in the biopsy. Why do we need to do that? I'll just show you this case where superficial biopsy showed only fibrosis and inflammation, which would have made you diagnose this case as non-specific orbital inflammation, and you would have perhaps treated this child with steroids with disastrous consequences because he actually has rhabdomyosarcoma. And the superficial fibrosis and inflammation was a reactive process by the body because of a necrotic round cell tumor, which was there. So you have to be very clear when you biopsy children, especially when you think of round cell tumors. This was a bilateral orbital mass with acquired telecanthus. You can see flattening of the nasal bridge as well. We thought it could be vaginous. Superficial biopsy showed inflammation and fibrosis. Deep biopsy was suggestive of vaginous because he had granulomatous inflammation, but there were multinucleate giant cells. So we asked our pathologist to do a special stain, which is GMS stain, and that was very clinching in terms of diagnosis because it was fungal granuloma, where use of steroids would have been disastrous. So orbital biopsy should be a layered approach, superficial, intermediate, well past the epicenter, and in the given situation where you really need a confirmation of diagnosis, you should ask for a special stain as well. Excisional biopsy is reserved for benign and malignant tumors, which are well circumscribed. Irrespective of what could be the final diagnosis, if the tumor is well circumscribed and it is not related to any of the critical structures in the orbit which may cause functional deficit, you should go ahead with excision. There is no reason to biopsy a well circumscribed orbital mass. You have to excise it. The approaches are many, and we currently favor transconjunctival approaches for tumors which are in the medial, inferior, and lateral orbit. Except those in the superior orbit where you have to go through the levator, we avoid this approach, but rest of the incisions are very, very conservative and accessible. Patients of this sort, dermoid, obviously lymphangioma, you can do a vertical lid split. This could be dealt with by a subrow incision for an incisional biopsy. These are some of the lateral orbitotomy incisions. But what is really caught on is the minimal access surgery. These are the transconjunctival approaches here, which could give you access to the medial, inferior, and lateral orbit. We generally go by the transfornical approach rather than transperilimbal approach. This was a child with orbital teratoma, but unfortunately the tumor lesion was on both the sides of the optic nerve. Here we approach by inferior transconjunctival approach with a lateral canthotomy and inferior cantholysis. This is the cystic component which was on the lateral aspect, and that's the optic nerve. Since we do surgery under an operating microscope, you can visualize all the structures. Nothing is left to imagination when you can visualize, and that is the medial or solid component which was medial to the optic nerve, and that was a lesion that was excised. This was a groove through which the optic nerve was traveling, and the child has good results except for the esotropia, which is persisting, which will need some repair. Now, this was a young lady with intraconal orbital mass, which was a cavernous hemangioma. I'll go through this video very quickly. You can see that that's the approach that we are making, lateral canthotomy and inferior cantholysis. In some situations, you can actually avoid lateral canthotomy and inferior cantholysis. Then you go directly to the periosteum. That's about 2 to 3 millimeter below the inferior orbital margin. Then do a periorbital dissection till you reach one of the endpoints, either inferior orbital fissure, the apex of which, or the infraorbital nerve. You don't want to transgress either of these two structures. And then you further dissect the periorbita in the area where the tumor is located, dissect the tumor to about 40 to 70% of its extent, and then use a cryoprobe for a gentle hold on the tumor anteroposterior traction and wriggle the tumor out. And as it comes out, look for the posterior vascular pedicle, which you're supposed to cauterize, and closure becomes very easy. I'll skip all this, just a bit about multimodal treatment. Multimodal treatment is a combination of surgery, radiation, and chemotherapy, which you are supposed to use in a given situation such as rhabdomyosarcoma or adenoid cystic carcinoma. It can really change the prognosis in the management of adenoid cystic carcinoma of the lacrimal gland. When you begin with chemoreduction, reduce the tumor, make it more consolidated, then you do a en-bloc excision, and finally follow it with adjuvant extended field radiation and adjuvant chemotherapy as well, where many of these eyes which were otherwise destined to orbital exentration, or many of these patients who are otherwise destined to systemic metastasis, can be very well salvaged. And even in patients who have a bone lesion like this, where the bone is involved, can have complete remodeling of the bone, as you see here, without any orbitectomy that is required. So in conclusion, I would say that logical approach to orbital tumors, beginning with a good clinico-radiological correlation, a customized plan for a given patient, use of histopathology for confirmation of diagnosis, and adjuvant treatment can optimize outcome. Thank you so much. Sorry for exceeding time.
Thank you, Dr. Santosh.